physiotherapist. And today we are having a session on role of occupational therapy and their role in the improving quality of life patients in palliative care. And today we have a faculty, he's Shashidhar Rao sir, and he's currently working as a professor in College of Occupational Therapy, Coimbatore, KMCH, and he completed his Master's in Occupational Therapy from All India Institute of Physical Medicine and Rehabilitation, Mumbai, and obtained a PhD from Manipal University. He has a total of more than 25 years of work experience in this field. And in that, around 17 years, he have been working with Manipal University. He have been a faculty over in Manipal University, and he's also worked as a faculty in abroad, Sridhi Sai Babasan Hospital and Research Center in Manipal. Then he moved to Kuwait University for 6 years and was associated with National Institute of Speech and Hearing in Trivandrum. He have been the HOD there in Occupational Therapy Department. And currently he's working as a principal of occupational therapy at KMCH, Coimbatore. We are happy to have you here, sir. And we are waiting to hear from you. And over to you, sir. Welcome, sir.
Yeah. So first of all, thanks for this introduction and a warm welcome to all the participants. Is my voice clear and audible?
Yes, sir.
Okay. So
presentation is not shared now. Can you please share it again?
I didn't get, what is that?
No, sir, actually, that presentation is not seeing now, sir.
Yeah, I think
Yes,
now
sir.
it is seen. Yeah,
Yes,
okay.
sir.
So I think my video might not be visible, but nevertheless, it doesn't make much difference. The reason being that my webcam of the laptop is not in a good condition. So the lightning effect, something gets spoiled there. And so I'll be presenting in without the video. And as to the participants, as was told to, as was given in the introduction, that in my earlier years of starting the career, I was associated with Kasturba Medical College. And there we started with the BOT and MOT occupational therapy program. And during the earlier years of my joining, I was also working for a very brief period in Shirdi Sai Baba Hospital, which is a specialty hospital dedicated only to cancer treatment. And then, of course, as we developed further, I had to move out from that place. And therefore, my experience with dealing with the cancer treatment is sort of not very large, but at the same time, it's sufficient to have some understanding about how the rehabilitation process can be initiated and what we need to look in providing the services to the patients. So, of course, as we all know that this is an area which professionals from various fields have to chip in their own unique contributions so that the life of the patient is more or less satisfied and they are able to come to terms with the disease and also try to accept the condition in a proper manner. So many professionals do play a role, and of which I think one of the professionals which is sort of not given much emphasis or input is with regard to the occupational therapy services. In the rehabilitation, if we see that as a healthcare sector, In that healthcare sector, the rehabilitation part, occupational therapy plays a or contributes to a lesser extent in making the rehabilitation process very successful. In the sense that when a patient comes with some chronic diseases which limits the patient in various functional activities, there are different professionals who addresses different needs of the patient, right from the physician, the diagnosis, the treatment, overcoming the symptoms, and then the complications of that, trying to overcome the various aspects of the physical, the mental, and the emotional changes which the patient undergoes. It's a long struggle for the patient to come to terms with it, and therefore various professionals comes into play a part there. With regard to the occupation therapy, it is of importance because when of all these treatments, when it is going on, addressing the symptoms and trying to improve the abilities of the patient, it is sort of uh, understood that improvement in one part can be directly correlated to the improvement in the functions of the patient. And as a result, say for example, if the pain and the some disabling symptoms improve, it is understood that probably once the symptoms decreases, the functions of the patient will tend to improve on its own. But that correlation is not so direct or linear. And in spite of improvement of the symptoms, there are certain residual functional loss which the patient has to deal with it. And to a greater extent, say, wherever possible, we can try to either restore those functional loss or try to compensate for what the functional loss is. So the patient has to carry out his daily activities of living. The patient has to participate in various roles and routines which are important for his or her family and for his life. So these things can be facilitated by giving certain restoration methods where we are giving some remedial approaches, or by using certain compensatory approaches. So the occupation therapy tries to fill that gap, that gap of making the patient function better in IADL or ADL activities. So where their functional limitations is most felt or is considered as the most important part of their living, so that they are able to live in a very satisfied manner. So that part is the we can say occupation therapy serves as that link which connects the various professions in making the patient improving in their functional activities. So the topic of this presentation is trying to focus on what are the various functional limitations that patients with cancer faces, and how, as a physiotherapist or as an occupation therapist or as a team, how we can try to measure them and how we can try to give treatment or intervention to them. Because when a person comes to the professional help, it begins first with by estimating what is the impact of the disease. So when we estimate that, we are doing nothing but performing certain evaluations. So evaluation forms an important part of the treatment. And then once that is said, then we have to determine the goals and try to achieve that goals. So this is how the broad flow of this presentation is going to be like. So as we begin with the next, with this presentation, some introduction information about what happens, the data, the epidemiology related things. Say India ranks third among the nations in terms of the highest number of cancers, as per the cancer register program, which is national level of 2022. There are various causes been attributed to it. of them being sedentary lifestyles, obesity, consumption of tobacco and alcohol on rise, and also increased, say, the age of the living. So as we tend to live little longer, the chances of confronting with this disease also tends to increase. So these are the various things which tend to contribute. And it's also been observed like the most common form of cancer in India are primarily the breast cancer, followed by lung, cervical, and the oral cancer, as per the ISMR data. So these proportions of the various common forms could be changing here and there, depending upon the reason and state. But largely, we can agree that uh, worldwide, this is the trend which is seen with respect to the cancer patients. So when a patient suffers with this, what is the impact of the condition is that the patient has to undergo the medical instability, that is the physiological processes is compromised, and that itself creates a lot of the discomfort and a sort of, say, unable to deal with the condition because the normal physiology is not functioning in them, and as a result it is reflected in their functional ability. So when this functional ability is limited, the patient's independence in their functional activities also tends to decrease, and therefore the patient is more dependent on the other. He tends to withdraw from various kinds of participations which are essential for his own life and for the family, and as a result that sets it into a vicious cycle in which lack of functional ability, lack of skills to certain extent, lack of motivation, and then leading to depression, and then that again contributing to the lack of functional ability. So this kind of vicious cycle the patient has to undergo, and that affects ultimately the quality of life of the patient. So the patient with cancer generally report of having symptoms that are sustained over a long period of time. They become very chronic, and then although there are various kinds of interventions have been given to address these things, but these interventions, they themselves come with certain side effects which further may, in some patients, can further complicate the functional ability and the independence. And then the patient also reports about the exercise intolerance. That means the patient endurance, we can say, is no longer as it is used to be, and therefore the patient tends to find difficult in doing the regular activities in a regular manner. And then this all leads to a physical deconditioning, in which the patient will tend to more and more restrict himself, to confines himself to the bed, and that itself can further make the symptoms aggravate, and also the physical endurance tend to decrease. Overall, all these things contributes the patient's inability to function, and also being independent in their daily life. So some of the declines in the abilities are linked to the side effects of the cancer treatment, of the cancer itself, and of the treatment which the patient has to undergo. So the treatment of various types, you would have already must be familiar by now. Say we have chemotherapy, radiation therapy. So in that, they themselves come with some amount of the side effects. They damage certain normal functioning of the body systems, and that leads to inability or functional loss. So we see that some of the side effects which the cancer treatment can affect, we can classify them as acute, long-term, and late-term. So acute is something like early. So up to 7 to 10 days can be considered as acute side effects resulting from cancer treatment. Long term, which is around up to 1.5 years of age after the treatment. And some of these can become a permanent feature. And late term, which can be lasting from 5 to 20 years of the post-treatment sessions. So what we are seeing here is not only the disease by itself is making the patient uh, dysfunctional or lose his ability to function, but at the same time, even the cancer treatment is making the patient to lose his ability to function in a proper manner. So the factors that lead to decreased ADL functioning following the cancer-related surgeries include increased age, complications from the surgery, which can further attribute to hospitals readmissions, and then the previous history of any functional declines. So as if the radiation and the chemotherapy doesn't work out, then they have to go for surgery, and they themselves, it can lead to further loss in the functioning. So some of the effect of this disease, which makes the patient unable to participate in daily activities, are fatigue, dizziness, and weakness. Now, all these things can be directly related to the disease, or it can be side effect of the treatment which the patient is undergoing. So, for example, weakness. Weakness generally arises from different kinds of neuropathies, which can be arising from the main cause of the cancer or from the treatment, which is maybe certain chemotherapy, which are neurotoxic in nature, or certain radiation form of therapy in which it damages certain nerves of the body, and that leads to weakness in the limbs and resulting into functional loss. So we'll be seeing about these things and how it affects the participation in various activities. So fatigue is one of the most important symptom or the side effect which affects this patient's participation in functional activities. And it is described as a distressing and persistent subjective sense of tiredness. So as we note here, the patient finds as so exhausting from the normal daily routine activities which the patient does. And this is a very subjective sense. That is why it is not proportional to the recent activity which the patient has to undergo, and that interferes with the usual functioning of the patient. So you may find that the patient might not be active or moving around, or you may find that the patient is more or less confined to the bed, but also complaining about fatigue. So it might be difficult for a newcomer or patient who are working with them to understand that when the patient is not doing the regular activities or participating in a very limited manner and more or less is confined to the bed, still the patient is complaining of fatigue. So these things can happen. So that is why it is called, this fatigue is not directly proportional to the recent activity in which the patient tends to participate. And this affects the all the functional aspect of the patient. So these are termed as cancer-related fatigue, or abbreviated as CRF, and it involves, or we can say it affects the physical part, the body, the emotional, and the cognitive functions. Okay, so the fatigue can have its impact on these three functionings of the patient. So the common side effect of the cancer therapies, it is found that 70% of the patient is suffering with the cancer-related fatigue. 22% of them, they suffer with nausea, and 10% of them suffer with the depression. These are some of the common side effects, and we see that the large proportion is suffering with the cancer-related fatigue. So 33% of the survivors will have persistent fatigue for many years after the treatment. So almost say 1/3 of the people tend to have this fatigueness associated with the cancer or cancer related treatments. And it is worsened by too much rest or lack of activity. So in this way, although we find that a common prescription is that when a person is having certain complaints of fatigueness or tiredness, we'll tell them to take rest. So here it is seen that the cancer related fatigue is worsened by taking too much of rest also. So it is important that the patient engages in some form of activity within his or her abilities on a day-to-day basis, so that this cancer related fatigue can be sort of minimized. Okay. And this cancer related fatigue is should be a forming an important goal in all the rehab programs. In all the rehab programs, in the sense, whatever may be the stage of the rehab programs, say early stages of rehabilitation, inpatient stage, outpatient stage, or say acute stage, or we can also going into the home stage. So whichever may be the phases of the rehabilitation program, so CRF should constitute an important part which need to be addressed by the. So one of the goal to achieve to deal with the cancer related fatigue is that we need to reduce the fatigue in everyday life. So this we have seen that there is three things which are contributing. One is the physical part of it. So that means physical part, the patient experiences decreased strength. So that decreased strength and endurance itself makes the person have that feeling of tiredness. So he's no longer able to stand for a long period of time, or even assume a sitting position for a long period of time. So these are related to that kind of weaknesses. And other thing is that it is the kind of energy which is spent in this disease, it seems to be phenomenal, and that energy loss itself can be contributing for the sense of tiredness. So high level of metabolic activity is taking place, and that consumes a lot of energy, and that itself can be contributing to the sort of, say, the fatigue to the body. So we have the pathological process which is contributing to the fatigue. The secondary causes, something like decrease in strength and decrease in endurance, which is contributing to the fatigue. And there could be also be something like the mental dealing with that. So the patient is uh, struggling to come in terms with the disease. So the patient usually tends to be in a depressed state. And when the person is in a depressed state and lack of motivation, we are, the fatigueness is also is seen as another form of manifestation of the depression. So this emotional the mood swings which the patient undergoes, and the depression component of the disease due to the inability to cope with it, so that itself can be contributing to the fatigue. So it is important that we see that the fatigue can be reduced. So when we say reduce fatigue, how can we do that? So there must be some guidelines, right? So these guidelines are from the cause. So the causes are what? The causes are could be directly related to the disease process, which we don't have much control on it. Maybe some form of therapy which is being, or treatment which is being given, can be addressing this part. And the second is the physical weakness part. So can we try to improve that? The third is the mental part. No, can we tend to improve that? So once we know what are the causes which are leading to this, we can form certain goals to address these causes, and that can help us to achieve a sort of minimize the fatigue. And also it is important that the rest and activity are in balance. So we have seen that more the patient tends to take rest, the more is the manifestation of the fatigueness. Okay, the mental state, the patient is not having enough motivation or energy to overcome that. So it is important that rest and activity balance is restored. Okay, and how it can be done. So it is important we can have certain form of schedules, a timetable sort of thing, that whether the patient is having enough motivation or enough energy to participate or not, the patient must do certain activities at specified interval of time. So this is what is an occupation therapy, the foundation of the occupation therapy is about. So whenever we talk about, say, functional independence, we do certain activities and we take all that things for granted, say our self-care performances, our participation in various roles and activities outside the home. So these things are all taking place at specified interval of time. And these, when we participate in specified interval of time, this becomes our roles and routines, right? So these routines gets affected in any form of the disease. You know, the routine of, say, what we did today. We got up in the morning, we have certain routines to follow, and this is how the life goes on. The activities are done in certain habit, in certain routine format. And by doing this in a routine format, we are trying to meet the roles of our individual, of our own individual. Okay, so we are trying to meet that roles. So any form of the disease, when it happens, these routines gets affected. So it is important that we realize that these routines are getting affected, and we try to bring some restoration in their routines. So the patient has to be made to participate in some, if not all, of the daily activities, in some or all of their instrumental activities of daily living, and in some or all of their roles and routines. So this is the where we can identify. Suppose if we are doing 7 to 8 activities in a day, can I make the patient to do these at least say 2 or 3 in a proper routine on a day-to-day basis? So this is how the rest and activity balance can be attained, by focusing on the routine of the patient. So whether the patient is in a hospital, sort of say not in acute stage, but recovering some sort of say subacute phase, or about to get discharged. So when the patient is in that stage, we can introduce this routine to the patient. We can give them the timetable, giving them an importance of why they should do these activities at some point or the other, and how it is important that whether they are enjoying it or not, still they have to perform these activities. And once they start doing these activities, probably they'll also connect to that and also trying to enjoy the process of engaging with them. So this is how we can try to get their life back, by participating in activities and also focusing on the rest and activity, so that the fatigue is also minimized. So OTs and also other people who are working with them, say other rehabilitation professionals, including physiotherapists, including nurses, they should have this idea about what are the barriers that are affecting the person, say in their physical activity, and how we can tend to restore them. So this way we can try to make them more engaged in daily activities, and also tend to decrease the cancer related fatigue. So it is seen that 60 to 90% of the cancer patient exhibit impairment that is affecting the functions. So it's a huge number. 60 to 90% of the patients are suffering with some functions. And that is why, as I started my my talk, I said that this particular role is sort of undermined, or we don't give much emphasis to that, because most of the emphasis is on decreasing the symptoms and trying to make the patient achieve certain immediate goals. But is the patient able to perform certain activities when they go back home? Is the patient able to participate in the activities when they go back home? That part is sort of, overlooked. And that is why it is important that we addresses them, and we can get them participate in their activities and trying to improve their satisfaction of quality of living also. And therefore, it has to be referred to the rehab at every stage of the disease process. So when we talk about the functional loss, we have certain, um, we can divide these functionality into basic ADLs. Like say, these are the fundamental skills typically needed to manage the basic physical needs, which are in the area of grooming, bathing, dressing, toileting, transferring, and eating. So these are considered as our basic ADL activities. These functional skills are mastered early in life, and they're relatively more preserved. So physical functioning is considered as the most significant driver of this basic ADL activity. So what it means to say is that in order to perform in these activities, the patient should have good physical factors. That includes your range of motion, muscle strength, normal sensation, coordination, and then the various type of sensory motor integration which takes place. So once they have these kinds of these kinds of physical functioning, the performances in the ADLs can be achieved. And these are the things which are sort of remains for a long period of time in all the disease conditions. The areas that are most significantly affected due to cancer are grooming, bathing, dressing, and functional mobility. It is surprising to see that feeding is not included here. And in fact, feeding is the one which is lost late, much late in the disease process. The first thing which is lost is their ability to groom themselves, because grooming, although it depends upon the physical functioning, there is some amount of cognitive participation which takes place. And this cognitive participation, they tend to be little lesser in the patients suffering with cancer. And therefore, the grooming part is sort of neglected in the patient. The another reason for that could be the patients suffer with depression. And as when there is a depression is prominent, we tend to generally ignore the way we look or to groom ourselves. Therefore, in them, the grooming becomes a very a factor, a component which is lost early. And including the other things are bathing, the sense of dressing in a proper manner, the excitement which the person has in wearing a good dress, that is lost in them. And therefore, the patient's roles gets affected, and also which is lost is the functional mobility. So the impact of functional decline of ADLs and on the quality of life is highly significant. So in the sense, like when the patient loses all these ADL performances, the patient will express that the satisfaction from his daily life is not very at a high level. So this is from the references which is given below, which we have obtained. The other kind of activities which gets affected other than the ADL is called as the instrumental activities of daily living. So these are more complex activities that are related to independent living, and it is also important to participate in the community. So these includes something like managing finances and also the medication part. There are many whole lists which we'll be seeing in the next slide. So this is another activities of daily living which is significantly affected. So ability to perform IADL is necessary for the maintenance of independent living, well-being, and also to achieve health-related quality of life. Some of the ADL related activities are management of finances, shopping, meal planning and preparation, laundry, house cleaning, ability to use communication devices, including mobile phones, management of medications, that is self-administration of medication on the timely basis, home maintenance, and driving. The last component is not a very popular thing in India, but all the other things are more or less a universal thing. So what we find here is when the disease strikes, when the disease hits a person, uh, the first thing which is lost is the ideal. You know, the person tends to withdraw from participating in these activities. May not like to go for shopping, may not be having a good planning skills for meals or for laundry, and so far, and whatever we are seeing in this chart, where these things gets affected. The reason for that being because all of these require an intense cognitive participation. Whatever activity you choose from this list, all will be having planning and organization of space, of time, and of resources. So when such planning becomes very highly intense, the patient is no longer in that state of dealing with it. And gradually, one by one, all these activities tends to get affected. So knowing this, what we can do is first to assess what is the level of IADL participation. What are the factors which are limiting the IADL participation? Two factors which can strongly limit is the physical functioning, and second is the cognitive functioning. So we must have certain assessment tools to measure these things and see how they are correlated with their IADL functioning. Once we identify these things, then we can have the treatment or goals in place. And that's why it is important for us to understand what are the various functionings of the patient, how they are getting affected. Okay. So as I mentioned, like IADL function is usually lost before ADL functions. For example, cleaning, laundry, cooking, and shopping. And once these functional decline takes place, they can be of long term. Secondly, then a patient also might be having a mental block that what the people will say, when the patient goes out. The patient can have certain complications which may not be very visually appealing. For example, lymphedema or breast cancer following the treatment of breast cancer. So these things also can limit the person to participate in IADL activities. One is the actual physical loss, and the other is their mental adjustment to the disease or to the treatment complications which are arising from that. And it is not a simple thing. I mean, it may not be even possible to address these things, but as a therapist, as a rehabilitation professionals, we should be keeping a track of these factors and how they must be affecting their functions. So once these IADL and ADL functions gets affected, the roles and routines, which is the next part, which is generally overlooked or not even given an emphasis on assessments. How is the roles of the patient getting affected? For example, a female, how is the role of the female gets affected due to the disease process? The role of the female could be as a homemaker, as a care, as a support or caregiver to the children, as a support or caregiver to the other elder people in the family. No, so this can be like two simple common roles which we can identify of any female. Now these roles are not addressed. The role of playing like a mother, the role of a grandmother. Now these things are affected. So can we do something to make the patient participate in these things? Now, to give an example, in one of my interaction with a very old lady who suffered with this breast cancer, and following that there was a strong complications in the shoulder of the patient. Shoulder hand syndrome sort of thing are developed. So in that, her one of the factor which she mentioned is that she will not be able to carry her grandchild. So that role is something which can be easily overlooked, or we won't have even thought about it. How a lady grandmother is thinking about what kind of role is getting affected. So how just to lift her grandchild is not able, she is finding it difficult. So she's not able to play that role properly, and that is making her sad. So what can be done so that that role can be encouraged? Now there is an issue of safety. There is an issue of, again, satisfying this grandmother's feelings. So a sort of, say, what we did was, like, say, we made with the properly, the child was properly wrapped in with all that safety and all, and we gave the child to her for, on a, say, 5 minutes basis, and that to hold. On that holding was all with guided, and people were there to take care and all these things. So but that contact was essential for her to keep her satisfied with the role performance. So these kinds of things are generally overlooked. A role of a lady, a role of a gent. Now imagine a child suffering with this cancer and the role getting affected. So it is not simple. It's not viewing symptoms alone, but seeing that how the symptoms are affecting their ADL, IADL, roles and routines. And just by looking at it does not mean that we are giving a magical treatment in all the things. No. As I said earlier, for some cases, it may not be even possible to give any sort of intervention. But nevertheless, can we, thinking about it can give some solutions. So it is important that the professionals who are working in has to identify these things also. Because if you don't think about it, definitely we're not going to give it intervention to that. If we start thinking, probably we can come up with some solutions, if not in all, at least in one or some of them. So that is what is, we have to change our mindset in how the rehabilitation program has to be planned, particularly when the patient is going back to home, going back to the community. What are the roles and routines and how we can be addressed. So all these things contribute to the quality of living of the patient. The various roles, routines, the participation in activities, all these things contributes in the quality of life. And that is why it is important that not only we are addressing these functional loss, but at the same time keep track about the quality of life. Because once we start assessing the quality of life, we will again note or identify some of the problems in the quality of life and probably try to address them. So it's important that all these assessments are being gathered, the data has been gathered from the patient. For some of us, it might look like, oh, what are we going to do with this? Yes, I would say for majority of the cases that might be happening. But if you are able to address on, say, few of them also, it could be making a meaningful differences to those patients. So it is very important to at least identify these kind of functional deficits. So it is important that assessments of IADS are done, because they can be showing us the beginning of the decline. Because the moment the patient starts to withdrawing from IADL activities, it will show that there is a decline in the physical part, the cognitive part, or both, and then how we can make them restore to make it in a proper manner. So we need to do certain form of functional assessments. So it has been reported that cancer has a negative impact on the functional status. The functional assessments can be broadly categorized into two. which can be, say, physical endurance and balance related assessments. And then the other could be activity performance assessment. So in both these cases, the assessments can be done by direct and actual performance, or can be obtained through a questionnaire based instrument tools or survey kind of methods. So we'll be seeing about how these two kinds of assessments can be done to identify the functional assessment of the patient. So one of the things which is given in the list of the assessment tools used commonly for patients suffering with cancer is the time up and go tool. This is a very popular tool among the physiotherapists. It can be used in various categories of age, and also particularly in geriatric related, or also can be used with neurological affected cases. And it is also a useful tool to be used with the cancer patients. So basically what does it does? It measures the speed during the several functional maneuvers. So which includes standing up, walking, turning, and then sitting down. For something similar to this tool is a 6-minute walk test. Again, a very popular tool among the physiotherapists. And this has been proposed as a single measurement tool for the functional status. But what we need to see here is that these two tools are measuring functions, but at different kinds of functions. Primarily the physical functioning. That means something which is related to muscle strength, endurance. So those things are getting. Yeah, I've been just got a note that we are losing time. So I just rush through that. Yes. So this is a kind of test which can be used with them. Then we have a TNT test, which is a neurological test, which is assesses the mobility, balance, and the gait. So this time up and go method, something like, so this is the basic administration of this test. We instruct the patient to stand up from the chair, walk to the line on the floor at the normal pace, turn and walk back to the chair at your normal pace, and then sit down. So when the therapist says go, the test begins, and we need to record the time. There can be various things which can affect the performance, something like slow tentative pace, loss of balance, short strides. So all these things can be affecting the performances also. So this is how the stand up and go can be performed. Whoever takes more than 12 seconds is considered of high risk of falling. So this is also be a tool used with the patient with the cancer. The other is the 6-minute walk test. Walk along. So in this, the patient is made to walk at a distance of around 30 meters, which is separated, and then the patient has to do the walking up to 6 minutes. So there are various data which gives that how much the patient can normally walk, and if they are falling short of it, it can indicate the functional loss. Then this is the test for the performance-oriented mobility assessment. So this is basically it assesses the mobility, balance, and gait. We have, so this is the chart which assesses the balance and the gait part. And it is scored on a 0 to 2 scale. And basically it gives them a risk for falling, which can be directly related to the patients with the cancers or following the complications of the cancers. So that is one. Then we have some of the functional status questionnaires, like say performance status can be measured by Karnofsky performance status scale, then Eastern Cooperative Oncology Group scale, and then a WHO prescribed scale. Then these geriatric assessments of functional status include evaluation of activities of daily living and activities of instrumental activities of daily living. So these are the two widely used methods to assess the functional status of the patient, that is the ECOG scale and the performance status scale. So both these scales are in public domain, and we can try to get these things to understand how these scales are used and assessed. So it is a Karnofsky scale is about predicting the length of survival of the terminally ill patient. It is a 11-point scale. A 10 points increment is given. So something like this is the Karnofsky scale. So this will basically give you the functional status of the person. So if it is 100, there are normal and no complaints and no evidence of the disease. If it is 0, the patient is dead. And in between, there are different kinds of ability of the patient to work. Say between 80 to 100, the patient can carry out normal activity and to work, and no special care is needed. Between 50 to 70, unable to work, able to live at home and care for the most of the personal needs. Between 0 to 40, unable to care for self, disease is progressing rapidly, requires institutional care or the hospital care. So this is how we can group their functional status. Similar on this line, very similar to the previous Karnofsky scale, is that ECOG scale. Again, this is on a 5-point scale. That was on a 100-point scale. This is on a 5-point scale. So largely, it begins with complete ambulation and not participating in strenuous activity, however able to carry out work on a light or sedentary nature. So this is how they can do. And gradually the functional abilities tends to decrease. Like in number 2, they're ambulatory and capable of all self-care, unable to carry out any work activities. They are up about for nearly 50% of their waking hours. In the 3rd, they're capable of only limited self-care, and they are confined to bed, and they are more than 50% of the waking hours. Then 4th, they're completely disabled, cannot carry any self-care activities, and they're totally confined to the bed. So this is one of the quick assessment which shows their performance status. And then we have ADL and IADL skills. On these things can be checked. Disability relating to ADL, that is difficulty with or requiring assistance in at least one activity, have been associated with poorer health related quality of life and considered as the predictor of mortality in the elderly people. So IADL is largely affected in patients with cancer. Nearly 1/3 of the patient need assistance to perform basic ADL, and half of them needed assistance to perform IADL. So this is, we can say 50% of the people lose their ability to perform IADLs. So the most commonly affected ADLs include walking and transfers, housework, and then shopping and transportation. Therefore, reduction of disability relating to IADL should be the main goal of the clinical management. So patients with cancer tend to have greater disability in performing IADL than basic ADL. Patients with breast cancer reveals worst scores on IADL. So IADL has been associated with poor survival skills. It has been associated with unexpected hospitalization and also for higher mortality in older adults. So IADL involvement is related with multiple cognitive factors, memory, processing speed, and executive functioning, and neuropsychological measures, including mood, anxiety, and depression. Association between neuropsychological functioning and IADL is of clinical importance. And IADL and neuropsychological assessments could be formal part of the routine oncological care. So in order to do this, we need to go for specific specific cognitive assessments and certain neuropsychological assessments. So some form of cognitive impairment, and this number is expected to grow in as the survival rate is improving. So cognitive impairment is a very common manifestation of the disease. Nearly 40% of the survivors have evidence of certain cancer-related cognitive impairment. So it is important that cognitive assessment is done as a routine for patients who are suffering with the cancers. These cognitive impairment can be related to directly to the to the disease process or to the treatment which they receive. So earlier it was thought that the neurotoxicity of the drugs which is used is the contributing for the for the cognitive impairment. But now it is found that in spite of where patients who are not having these kind of neurotoxic drugs, they also suffer with the cognitive impairment. So there seems to be something, a general problem arising due to the condition also. And this forms an important form of the assessment. So the test addresses, so we have something called a short blast test. So this test concerns the cognitive areas of orientation, memory, and concentration. The purpose of this test is to serve as a screening tool to determine the cognitive changes associated with dementia. So we have something like SBT. So this is how it is checked. It is having a ordinal scale kind of data, and all has a 6 questions. And based upon that, we can check the quick, it's a screening tool. So this screening tool helps to give the orientation, memory, and concentration. So we have certain score ranges which can indicate either normal or minimal impairment, or moderate and severe kind of impairment. This can be used by any professionals. It doesn't require any specific training for administration. Then we have a dementia screening tool. Again, it is a self-administered tool, and so this is again a common tool which is used in patients with not only with the elderly, neurological affected, but also with the cancer. So it is a 8-point tool, and basically the patient self-reports on the kind of changes which is happening to him or her. So that self-report changes can indicate the kind of functional impairment the patient has. So this highlights the need for thorough assessment of the challenges and needs in the population and contribution of occupational therapists in a holistic management of the clients with the cancer. So when we check for the activities of daily living, we can go for either observational assessment of EDL performance, which is generally in most of the cases it is impractical directly observing them, and therefore we rely on largely self-report basis of the ADL and IADL performance, or a combination of observation and self-report. So observational assessments can be done in some or all of these activities: how the patient bathe, how the patient bladder and bowel manage, dress, eating. So all these things will indicate the functional skills, the cognitive participation, the emotional needs of the patient. So when the patient is doing these activities, the other factors which are contributing can also be taken, can be estimated how they can getting affected. So some of the observational assessments are, when the patient is doing those activities, we can check for the cognitive abilities, that is the ability to follow directions, physical abilities and limitations, mainly the muscle strength, range of motion, etc. Social skills, the willingness to interact with the therapist, risk-taking or suggestive behaviors, psychological status like paranoia, anxiety, depression. So all these things can be observed when the patient is doing or participating in those ADL activities. So it allows the therapist to observe and record behaviors in specific situations rather than on self-report. So when we self-report, there can be an error of overestimation or underestimation. So that can be avoided by making the patient directly perform. However, there can be certain limitations due to that also. So when there can be a functional independence measure is FIM, which is commonly used tool. It can be used across, it's the generic assessment tools. It can be used with various category of the patients. So it is an 18-item standardized tool. It assesses 6 main areas of function under 2 different dimensions, motor and cognitive. It is a 7-point scale, and highest score indicates more independence. So it's again available in the public domain that can be used. So these are the various components which is addressed by the FIM: self-care, bladder bowel, mobility, locomotion, and all these 6 components are scored on a 7-point scale. Then we have certain specific disability assessment tool. The most common one which is used is the CARDS index, independence in ADL, and Lawton Brody's IADL scale. So CARDS index, even we can use Barthel index also can be used. Yeah, but since it is more developed for patients with hemiplegia, the use of Barthel index in patients with cancer is very limited. However, yes, there is no hard and fast rule that we cannot use that. Largely, CARDS index is used. And then some of the studies included fewer additional ADL items using modification of these standardized measures. So what it says is that there are limited studies which has done the effect of ADL due to cancers, and also the IADL performance due to cancers. So the lack of that is they don't use standardized tools, or whenever they're using standardized tool, they don't use it to the full extent. There are certain modifications and cultural specific adaptations are made, and that actually affects the generalization of the data. So that is one reason where we have to take care in using these tools. So according to CARDS, older adults follow an episode of illness, regaining, recovering basic ADLs in hierarchical or developmental order. So these are some of the various active problems which are affected in them. In the most prevalent ADL activity which is lost is personal hygiene, followed by disability to walking and transverse and bathing. Most prevalent IADL is housework, followed by shopping and transportation. The least prevalent ADL is eating and stair climbing, which is affected. And the least prevalent IADL which is affected is telephone use, handling finances, and medications and the management. So this is based upon a particular study which they analyzed, like what are the different kind of severity of functional losses are experienced by people with the cancer. So IADL assessment as done by Lawton and Brody, it is an independent living skill. It identifies how a person is functioning at the present time and to identify improvement or deterioration over time. It provides self-reported information about functional skill necessary to live in the community. So this is the Lawton scale, which has 0 to 1 kind of score. 0 does not do, and 1 will have certain form of performances in all these activities. So it's again available in the public domain. So once we get an information about that, we know which kind of ADL is largely affected, and then in consultation with the patient, we can try to address them. So we have again a European Organization for Research and Treatment Cancer quality of life questionnaire. So this is a quality of life questionnaire, which is again a large scale consisting of around 30 questions. Okay, and this can also give a quick idea about their quality of life and how these functions are related. So basically, it is a 30-item specific questionnaire related to cancer health related quality of life. It consists of 5 multi-item scale of functioning, 3 multi-item scale on fatigue, nausea, and vomiting, 6 single item on various kinds of autonomical nervous system problems, and 2 items on global health and global questionnaire of quality of living. So what can be done? Interventions. Occupational therapy can promote functional ability that includes restoration and compensatory strategies during the ADLs and IADL. So in some form, there can be, we can try to restore in the functional losses which takes place. And the majority of the cases, we may have to go for compensatory strategies. So in the compensatory strategies, we may have to do certain modification, splints and adaptive devices, how to use those adaptive devices at home, how to use the mobility devices. So these are the various kinds of training which can be incorporated during the rehabilitation phase. And we also have to introduce, say, some of the activities participation, roles and routines participation. So some like physical, dance, emotional, poetry and scrape. Some hobbies of the patients can be explored and they can be made to participate in them. Sensory, something like cooking and gardening, educational related things can also be told to them. So these are the various kinds of interventions that can be implemented so that in general, their functional performances can be slightly improved. So another way of dealing with this particular aspect is the use of COPM, that is Canadian Occupational Performance Measure. It's a tool which highlights the deficits and also highlights the satisfaction in the performances. So that can be shown to assess pre and post interventions in these areas, because it's hard to detect changes in strength or in certain emotions to say that the particular therapy or the time spent in the therapy is really beneficial to the patient. So we need to go for certain scales where it can generally capture the improvements on a broad parameters. So in such broad parameters could be use of Canadian Occupational Performance Measure Scale. So these kinds of things can be identified once we go with the assessment of certain things. So some of these these are some of the references which have been used to prepare this presentation. And yeah, so basically we are concluding by saying that the functional loss is one of the things which is slightly overlooked in the rehabilitation phase. Not much of emphasis is given on ADL, IADL roles and routines, participation of the patient. And therefore, in order to give interventions in these areas, we should have certain assessment tools which give, it can be a screening tool or it can be in-depth assessment tools. Based on that, we can form certain goals to address in some of these areas of deficits or functioning problems. So, and then once we start thinking about those kinds of deficits, some kind of solutions in the form of restoration or compensatory methods can be planned. So with that, I conclude this presentation.
Thank you very much, sir. Thank you for your wonderful and informative presentation. And thank you for elaborating the introduction to occupational therapists, the role of occupational therapists in rehab and all, and listing the ADL and other tools. Thank you very much, sir. If you have any doubts or any comments, you can type in the chat box. Now it's time to move on to the case presentation. And today case will be presented by our participant, Judith. And I welcome Ms. Judith for the presentation, and over to you, Judith.
Good afternoon, everyone. Today, my topic is functional ability and quality among patient in palliative care and the role of occupational therapy. So I have taken a case who is having 45 years old, and he is a male, and he is diagnosed with failed back syndrome. The presenting complaints are chronic pain in the low back area radiating towards the right lower limb, chronic indurated edema, and occasional numbness. He can't perform the activities of the daily living properly, can't even maintain sitting, standing, and lying position for a long, can't sleep more than 4 hours at night, but have to lie down in the late time for adjusting the position, depressed because of his condition and having incontinence of the urine. Next slide. History of the illness. In 2016, he fell down from the ladder of second floor to first floor in a construction site in Gulf, and he landed on foot. Thus resulted in fracture of the toes. After treating the fracture from abroad, he came back to India and started construction of his own house. For that, he carried blocks as an axial head block and resulted in low back pain and IVDP. and he has performed a mild discectomy in 2016. The symptoms aggravated in the terminal of the 2014 and ended up with the failback syndrome, L5S1 recurrent IVDP. In 115, L5 laminectomy with removal of the L5 disc is done. In 2020, diffused annular disc bulge at L3, L4, L5, and S1 with central canal, central protrusion and caudal migration of the L3, L4, and L5, S1 levels was there. Narrowing of both lateral races and neural phenomena and indentation existing and transverse nerve roots at L3 to S1 level. Then there was straightening of the lumbar spine with bilateral facet edema at L4, L5 is found in the MRI findings. So examination, the conscious was alert, he was febrile and AMF was normal. The motor system bulk, the right and left were done. The right thigh, 11 centimeter above the patella, it was 53. And in the left leg, it was 52. And it's also done in 11 centimeter above the tibial tuberosity. It was right, it was 42, and left, it was 38. The muscle tone in the upper limb and lower limb were normal. The muscle power of the lower limb muscle groups were done. So the hip flexors having fifth grade. Hip flexors are also having fifth grade in both limb. Hip abductors, hip adductors, hip flexors, knee flexors and knee extensors are also having fifth grade, but the ankle plantar flexion was fourth grade in right limb, and also the inverters were also involved. It was fourth grade. Other than other muscle groups were having normal power. The treatment and significant investigation. The patient is mainly having this chronic pain and he is not able to do anything. Even he cannot maintain his position for such a long time. He can't do anything, his own personal things and all. So the main, he prefers the pain management. Though, so ultrasound continuous mode for 10 to 15 minutes is done. Occasionally the phonophoresis with diclofenac gel when pain is so much aggravated, he usually prefers. Then IFT 50 Hz for 10 minutes is beneficial in him, and also for the urinary incontinence, the IFT is given to him. Sometimes the combination therapy of both IFT and ultrasound is also done. The transcutaneous nerve stimulation is also done for the patient. It was being beneficial for reducing its pain. Psychological aspects. The patient is a middle-aged male with failback syndrome with obesity. After the surgery, his wife divorced him. So his mother is taking care of him, and he is depressed about his marriage life, health, financial support, and future. And he is having liability about 1 lakh. The patient is satisfied with the physiotherapy management, that is his pain management. But here the patient needs more role of occupational therapy. The person has to, is just a middle-aged person. So the role of the occupational therapy is more relevant in this case. He is often provide him mental support to do innovative ideas for daily living. He earlier performed as, after coming back to India, he has performed as an auto driver, but he can't drive for long. Now, so he just quit the job. Now he is act as an agent for buying land with his social contacts and making his earning. Medications, he is not having any lifestyle disorders, so he is not taking any medication. The main concerns: physical, have obesity and reduced physical activity, having addiction to smoking. Earlier it was having alcoholism, it was chronic, but he has stopped it. Psychological, he is depressed about his marriage life, job, health, and future, and he is not having any offspring. and he lives with his mom, and he concerned about her health also. Socioeconomic, having a low economy and have good social contacts in society, which helps him to live on. Spiritually, he believes in God and religious practices, and he aspires that he will can achieve. He is okay with the present condition, but he wishes to become more better. Summary: 45-year-old male having failed back syndrome truly depends upon the physiotherapy management for his existence. Without pain relieving modalities, he can't live. Suffers to earn. So for such person, he greatly depends upon his mother for every needs and has no offspring. In this case, the role of the occupational therapy is more significant for promoting his quality of life with the physiotherapy management. Discussion points. I have to read this?
Yes, Judith, I can read it.
Is further any spinal surgeries beneficial, such as spinal fusion after these all surgeries? What all therapies can be given for improving the quality of the life? Is there can be any other further betterment of his health? What advice can be given to be him? So thank you.
Thank you, Judith. Thank you for the case presentation. And we have heard the presentation, and these are the discussion point of this 45-year-old male patient who is having a failed back syndrome. And I request our participants to give comments and suggestions for these patients and to his interventions. And finally, we can ask to Dr. Shashidhar Rao for the occupational therapy interventions. But before that, I request our participants to come up with your ideas. So anyone would like to come and speak about this case?
So may I?
Yes, go on.
Sir, since it is a case of failed back syndrome, that means the surgery has already been done a number of times, and there is no success has been achieved in this case. So further surgical intervention is not beneficial in this patient. From physiotherapy of point of view, we should work on first of all the pain reduction and then the strengthening of the muscles. For pain reduction, modalities can be used for reducing the pain, as well as like the K-taping can be done, in which the muscle technique can be done for the extensor, spinal extensor muscles. And after application of K-taping, we can go with the strengthening of the spinal extensor muscles. And apart from this, a good endurance program needs to be planned out for this patient, since the patient is gaining weight, and we need to see that part also, because more the weight, more will be the problem of back pain. So we need to work on that also. And we can give some supportive devices and good postural correction, or the postural devices needs to be advices needs to be given to the patient.
Thank you, Dr. Vandana. Thank you for your comments and suggestions. As Dr. Vandana said, we can give some endurance training and all, but I think most of the upper limb and lower limb muscles, they have grade 5. But I don't know, still he's not able to sit, right? Judith, he's having MMT almost, I think, except angle plantar flexion and inversion. All of the muscle grades are 5, right?
5.
But still, he's not able to sit or stand.
No.
Is that just because of his obesity or something else?
It's because he is too much obese, and he can maintain for half an hour or like 1 hour, but he cannot do it for a long any position. If standing is he is done, or walking for half an hour, then he is messed up, and the pain, there will be excruciating pain. he cannot tolerate. So he cannot do any activities beyond a limit. He is bound
Can he
to
do bridging or any core stabilization exercise like that?
he is very very adjusting, and I initially I tried all those things, but it seems that whenever any activity is doing, it's provoking the pain. I just prefer brisk walk for him for 15 to 20 minutes. He just can do, but the weight is not reducing. He is not consuming much, but it's like this.
Yeah, okay. As Dr. Manika Saxena has a comment on our chat box that core strengthening can be incorporated within pain limits. Even I was telling about that. You can start with a small amount of like core strengthening, core stability exercise. You can start with within the pain limit. You can start with a little bit core exercise. As you are told, he is having upper limb and lower limb muscle grade 5. Now you have to, it's time to concentrate on the core muscles. Manika, would you like to come up and speak? And we have some more comments on our chat box. Mr. Murugavel said that he might get help with cognitive behavior therapy, CBT, and graded exposure to painful activities. Dr. Priyanshu has commented that if there is pain on movement, focusing on isometrics of lower back muscles should help. Thank you for your comments and inputs. So as we have discussed, spinal surgery, I don't know whether it is beneficial or not, or we have to seek the help of any orthopedic surgeon. And therapies can be we can concentrate on core stabilization, or I don't know how much effective will be the 10 minutes of TENS. If you want, you can give a little more time with the TENS or something, if he is having radiating pain or something. And now we can ask Dr. Shashidhar sir for the to get some seek some help of some occupational therapy or something. Over to you, Shashidhar sir.
Yeah. Before I go into that, I just want to go through the case once again. Can you? The starting point, the first two slides, I think. Yes. The next one. Yeah. So you had mentioned like the patient is dependent on mother somewhere. I don't know which part it comes. I just want to know what is that he is dependent on the mother, on what activities?
He depend upon for food and other managing household things. He can't live alone. He can't cook. So he truly depends upon activities. If the pain is worsened, then his mom can take care of him, having hot packs and giving this massage something. If the physiotherapy management is immediately not available, he is being taken care by his mom.
Okay. So yeah, so it appears like he's having two issues here. One which is resulting from the spinal cord damage, the vertebral damage, and the other is partly resulting from the nerve root compression also. There is somewhere I read some urinary problem he had.
It was there, but now he is having much more control.
He is having much control.
Yeah.
So the compression part, if you rule out that part, I think the motor innervations are fine, as was pointed out. Only the ankle dorsiflexus seems to be grade 4, but that shouldn't be a big problem with respect to his gait and other aspects
Yes.
concerned. So he to me he looks like a more or less an adult who is able to do functional mobility or even community mobility also, because I just remember that you mentioning he's doing some activity, um, he's engaging in a work like a real estate agent. So that
Yes.
involves a lot of traveling, could be going to the site, showing to the customers, not only walking, but also it could be involving driving.
No,
Um,
he's not driving. He's having being in auto, and he goes. And usually, there are no much cases are there. Usually, he is now in backward condition. So he's just managing the things.
Mhm. So that means
Yes,
he doesn't have a proper work or to which he earns money, right?
yes,
He's not having that kind of. So now, if we rule out that part, now focusing upon is ADL and IADL. To me, he looks like he's having more or less an abled body,
yes, yes, sir.
including upper limb and lower limb. And since he was dealing with some amount of real estate thing, I think his cognitive abilities are also decent
Yes,
enough.
yes,
But at the
yes,
same time, we need to get a better picture about his cognitive functions. Okay.
okay,
The other thing is with regard to the obesity is another factor which is complicating the issue.
yes,
So
yes,
when
sir.
we talk about obesity, the his endurance level, the METs, and those things can be the physical conditioning part. I think somewhere that weight reduction program should constitute one of the treatment goal for
Yes,
him.
sir.
Um,
Nutritional therapy should be done, I think.
yes, how he's managing the diet, because obesity will have two kind of intervention: one the diet control, and then the activities, exercises. As mentioned by Ms. Judith, I think he has uh, he he doesn't have a good control over his diet. That's what you mentioned, right?
I think yes. He used to say, "I don't know how long I will live." He just said, "Let it be going like this."
Yeah.
Let's see. He
So
is enjoying all
that
those
looks
food
like
and
he's
he's
also having a depression. Some elements of depression is there. So we need
yes,
to first
he's
get, yeah, first we need to get this, and probably the point which you have, like any additional therapy is required. I think some psychologist consultation is
yes,
required for
yes.
him,
He
because
requires.
he is living a very depressed life. Um, uh, Although the proportion of his abilities and the loss, they are not tallying with the kind of problems he's facing. There are people who are much obese. How much is weight, by the way? BMI, how much is BMI?
BMI, I didn't take it. He is about the 170 centimeter, and he's having more than 120 kg.
I think it's not a big thing with that height and weight. To live a health, to live at least a life where he can participate. We
Yeah,
have we
yes, of
have
course.
seen in that proportion patients who are engaging in many aspects of their life.
Yes,
There are, I think he needs some kind of, he has to change his outlook
life.
about how he can participate and make. He is not that disabled in either way, be
No,
it considering
he's
his
not.
obesity or his functional. He's not that disabled for him to think about that he is undergoing a very severe crisis in his life. So that is one which we can try to have a good psychological consultation with them. The
Yes.
second is with regard to the functional things which he is losing. Again, his lack of motivation is the only thing which is not making him participate in most of the things. Um, if he has to say if he has to do certain exercise to reduce his weight, and if pain is the factor which is limiting it, he should be doing that exercises at a short interval of time, but spread over a long in a day, right? Multiple more frequency. You should be doing it more frequently, that kind of exercises. So for that, he has to be, I think, properly motivated to
Yes, sir.
participate in these things.
Yes,
Otherwise,
sir.
he's not having a much problem to experience such kind of functional limitations, which is pointing it out.
Earlier during the therapy, I used to always motivate him, but he is now like I am used to my condition.
Yeah,
Yeah.
he sort of given up with all his. So that is
Yes,
something. That attitude is something which need to be either
check.
as a therapist, whoever we are coming across, they should really make him realize that he's not having such a hopeless state that he has to give up with all of his activities. He can very well function with whatever abilities he's having remaining with. I think he can
Yes.
very well do with it. Now, addressing the ADL participation and IADL participation. So first ADL, uh, feeding, I mean, there are many activities, and I hope they are quite independent, like bathing, dressing. He does
Yeah.
all that thing. Only feeding is the problem. What exactly is the problem with that?
Actually, he is not having the much problem in a thing, but he can't just manage his weight and this pain. Because of this overweight, he's having a restriction, but it's difficult for him to reduce the weight. He tries for a bit of time, and when the weight is falling just for 1 or 2, then he is easily giving up. He is thinking that why I should do. I have no hope for another marriage or such things. He's thinking I'm just having a useless life. I call things he used to say whenever I used to motivate. I think he needs a good psychological therapy, and he should be motivated.
And also, we can try to make him in a group of similar patients who are doing a similar condition, but maybe coping better
Yes.
with similar kind of height and weight, obesity problem. People who are coping that condition in a proper manner, if he can be made to interact with them, I think that could also help him to change his own thinking about his own the way he's dealing with it. That could be one.
Yes.
That's what with the participation in ADL and IADL, I think it's lack of motivation which is preventing him.
Yes.
Because
Yes.
at this stage, if he has to become independent in cooking and self-care, cooking abilities, he should learn those prerequisites. He should have certain skills. That kind of thing, whether he is in a state to acquire that new learning, that is again a motivation. So first we need to know ADL, which are the ADL he thinks he's having a deficits and which he wants to improve. In that, the best scale will be COPM, Canadian Occupational Performance Measure. It is a very broad scale. It primarily says self-care. Self-care, it asks you to identify 5 activities which you consider as problematic. Okay, after you identify those 5, it will ask you to rate how important they are. And then it will ask you to rate how satisfied you are in that performance. So it's basically, it checks on how important is the activity to you and how satisfied is that activity performance. Okay, so it is important and satisfaction for each scale. So once he self rates on those things, of those many things, we can identify the top 2 or 3 ADL and IADL problems, which can be later thought about how to improve that. Because as of now, to me, he doesn't have any physical problems strong enough to make him dependent on any of these things. Neither he has a the most thing which is affecting is the motivation part of thing. So somewhere that kind of interventions we can think about it, and more self-rating on ADL assessments could be one of the factor one of the additional assessment which we can do.
Yes, sir. Thank you, sir.
With regard to spinal fusion and all, I really doubt, because
Yeah, possible after all
and we are
things.
not the right person, honestly. I think it has to be consulted with the orthopedic surgeon,
Yes,
and
sir.
because it will come with lot of complications, stiff spine, with again can have new set of, with again he can make that as an excuse to not to participate in many of the things.
Yes, sir.
So we need 2 more assessments to be done, and taking care of the obesity and psychological interventions. So this is the way I think we can further plan about it.
Okay, sir. Thank you, sir.
Thank you.
Thank you. Thank you very much, sir, for your suggestions and comments on this case. And I think it's something you might have got to do some intervention like psychological interventions and doing some film scale and promoting his ADL activities and all. So it was a overall good presentation and comments from sir. So I think it's time to wind up our this session. I thank each and every one of our participation for your time and your comments and everything, participation. And if you have any further discussion or something, we can discuss this case in our group, our WhatsApp group. So it's time to wind up, and we hand over to Vaishnav.